طيب صباح الخير جميعا. معكم عبد الرحمن, استشاري طب طوارئ, emergency medicine consultant. Today we'll talk about electrolyte disorders. أتوقع الشاشة عندكم واضحة صح في الباوربوينت presentation؟
واضح
ايوه
دكتور.
ممتاز.
ايوه
تمام.
واضح.
تمام. So we'll cover three main electrolyte disorders in this lecture, which is related to the sodium, potassium, and calcium. Those are the three main electrolyte disorders that we may encounter during our work in the emergency department or clinical practice in other specialties. The other electrolyte disorders are still important, but I think those are the most important ones, and we'll just focus on those three electrolytes today. So we'll start with the first electrolyte disorder, which is related to sodium. First of all, we'll talk about hyponatremia, or the low sodium level. Basically, it's defined as the sodium level low, or which is lower than 135 milliequivalent per liter. And to diagnose a patient with hyponatremia, we have to first figure out whether it's a true hyponatremia or a false hyponatremia. And what we mean by that is it associated with a low osmolality or not. So the true hyponatremia, or the hypotonic hyponatremia, is associated with a low osmolality, and the pseudo-hyponatremia usually is associated with a normal or actually high osmolality level. So can any one of you tell me what do we mean by the osmolality level? Any idea?
It's the percentage of the sodium particles corresponding to the volume.
Yeah, you're very close. So what we mean by the osmolality is basically it's the measurement of the dissolved particles in the volume. And as you said, the sodium contribute the most to the osmolality. That's why in true hyponatremia, we're expecting the osmolality to be low, or we're expecting the patient to be hypotonic. So this is the main difference between the two main types. Just a second, I think I stopped sharing. Anyway. As you can see in the table here, the main difference between the two types, the true hyponatremia and the pseudo-hyponatremia, is the osmolality level. And as we said, because the sodium contribute the most to the osmolality level, we're expecting it to be low in true hyponatremia. And in pseudo-hyponatremia, it should be high or sometimes normal because of the other particles in the volume that may falsely make the sodium level low and make the osmolality high. So the types or the causes of true hyponatremia, we usually classify them based on the body volume into three main types, including hypovolemic hyponatremia, hypervolemic hyponatremia, and euvolemic hyponatremia. And as we said, in cases of pseudo-hyponatremia, we may see this condition in which the patient has like other electrolytes that may make the osmolality high and the sodium level to be falsely low, but actually it's not low. And the examples or the causes of the pseudo-hyponatremia may include severe hyperglycemia, higher protein levels, such as in cases of multiple myeloma, and high triglyceride level, such as in cases of pancreatitis. And usually there are some equations that we can use to calculate the adjusted sodium level in those kind of cases. You don't need to know them. Just keep in mind that we have some equations that we may use to correct the sodium level. Okay, so once we confirm that the hyponatremia is true, as we said, we can classify the type of true hyponatremia into three main types: hypovolemic, euvolemic, and hypervolemic, based on the body volume. And those are the main causes of each subtype. So in cases of hypovolemia, as the name states, usually it's caused by causes of fluid loss, such as GI loss, vomiting, or diarrhea, third spacing, such as in cases of burns or pancreatitis. And what we mean by the third spacing is basically the shift of fluid from the intravascular space to the interstitial space. And the last cause may include as well diuretic use or renal losses. In cases of euvolemic hyponatremia, in which the patient will present with euvolemia or normal body volume, We may see this condition mainly in endocrine causes like hypothyroidism, adrenal insufficiency, and the syndrome of inappropriate ADH secretion. Just a quick question about this syndrome. Do you remember if the ADH is expected to be high or low in this syndrome?
High.
High, exactly, yeah. So that's why this will lead to increase in the antidiuretic hormone, which will prevent diuresis, and as a result, this will cause dilution of the sodium and low sodium level with a normal body volume. So it will not cause significant retention of fluid, but it will cause a drop in the sodium level. And the last cause of the euvolemic hyponatremia, usually we can see it as well in accidental or excessive water intake, such as in cases of psychogenic polydipsia, in which the patient usually drinks a large amount of fluid, in a large of unnecessary amount of fluid, and those kind of patients, they usually drink it without even feeling thirsty. And the last subtype, which is the hypervolemic hyponatremia, usually it is caused by a failure of three main organs, which regulates the body volume, which include either the heart or the liver or renal. So failure of those systems may cause, again, hypervolemia and hyponatremia as a result of the large body volume. Okay. We talked about the syndrome of inappropriate ADH secretion. You don't need to memorize all of the causes of this syndrome. Just remember that it might be caused by some CNS and pulmonary causes, including some infections and masses in those two systems, and some drugs such as narcotics and thiazide diuretics as well. Okay, so let's talk about the clinical feature of hyponatremia. Unfortunately, the features of hyponatremia are non-specific. The signs and symptoms of hyponatremia usually depends on the sodium level and how rapidly did the sodium level drop. For example, the acute and drop in the sodium level will cause more symptoms, and the lower the level of the sodium, the worse of the symptoms that we may accept in those patients. So with low levels, we're expecting worse symptoms, and with acute drop, we're expecting also severe symptoms. As we said, the features of hyponatremia are non-specific. Unfortunately, it may cause vomiting, generalized weakness, which can be seen in so many other medical conditions. What we need to know are the features of acute or severe hyponatremia, and we usually see those symptoms or a severe manifestation of hyponatremia when the sodium level drops below 120, and when it drops acutely over 1 or 2 days. And the severe hyponatremia usually can be characterized by the severe CNS symptoms, such as confusion, seizures, or coma. And in very severe cases, it may lead to respiratory arrest due to the brainstem herniation. And we need to know that because the treatment of this condition, the severe hyponatremia, is kind of different than the other, the treatment of other types of hyponatremia. I mean, the mild and moderate ones. We need to use a special treatment line, and we will talk about it later on. So we'll just move on to the clinical features that may help us with identifying the main type of true hyponatremia. So as the types state, the hypovolemic hyponatremia, we may expect some signs or symptoms of decreased body volume, such as increased capillary refill, dry mucous membranes, orthostatic hypotension, which is basically a drop in the blood pressure when the patient stands up or changes the position. And in cases of euvolemic hyponatremia, basically you will not see any signs or symptoms of hyper or hypovolemia. And in this last subtype, as the name states, in case of hypervolemic hyponatremia, we may see signs of hypervolemia, such as crackles on chest auscultation, lower limbs edema, and distended jugular vein. Please feel free to stop me at any time if you have any question. Otherwise, we will just move on. Okay, so how would you evaluate a patient with hyponatremia? Usually we order some blood and urine workup just to help us with, again, reaching the final diagnosis or the final cause of hyponatremia. And those include serum, electrolytes. So we have to check all of the other electrolytes in the body, including potassium, calcium, magnesium, because basically we may find another electrolyte disorder associated with the hyponatremia. And we measure also the serum osmolality, as we said in the first slide, to confirm that the hyponatremia is a true hyponatremia. And also we check the urine osmolality and urine sodium levels just to also find out the exact type of hyponatremia. So this chart mainly summarizes how useful are those workup tests that we may order to find out the reason. So as you can see, in cases of hypovolemic hyponatremia, the urine osmolality and urine sodium levels may help us in this condition to find out the reason. So as you can see, we're expecting the urine osmolality and urine sodium to be low if the cause of hyponatremia is from the GI tract or any extrarenal losses, such as the third spacing we talked about earlier. And in contrast, if the kidney is the cause of the sodium loss, so we're expecting the urine osmolality or the urine sodium to be normal to high, because the kidney basically is excreting the sodium into the urine, which makes the urine also osmolality high. Because again, as we said earlier, the sodium is the electrolyte that contributes the most to the osmolality level. And in cases of euvolemic hyponatremia, the urine osmolality can also help us. So as we said, one of the possible causes of euvolemic hyponatremia are psychogenic polydipsia, in which the patient drinks a large unnecessary amount of fluid, which will cause dilution again of the urine and will cause low osmolality level. And the other causes, the endocrine causes that we talked about, that may cause euvolemic hyponatremia, usually they cause normal urine osmolality, because those conditions, they do not dilute the urine, basically. Okay, so let's talk about the treatment of severe hyponatremia. So as we said earlier, we have to identify those patients, because the treatments for those patients are kind of different than the other patients with hyponatremia. So when the sodium level drops below 120, and the patient presents with severe neurological symptoms such as seizure, decreased level of consciousness, or in severe cases, apnea, we should use the 3% hypertonic saline. Basically, it's a type of IV fluid which contains a large amount of sodium compared to the other IV fluids. And we have to use it in this condition because we want to reverse the hyponatremia very fast, to avoid any further deterioration in the patient's clinical condition or possible arrest. So the dose, you don't have to memorize the dose. I just kept it here for your reference. We typically start with 100 ml, and we can repeat it so many times until the patient's condition or the severe symptoms improve. So that's for the treatment of severe hyponatremia. So what about patients with hyponatremia who present with mild or moderate symptoms? Usually, the treatment for those patients really depend on the type of hyponatremia. In cases of hypovolemic hyponatremia, usually we start with the boluses of isotonic sodium chloride, which is the 0.9%, which contains fewer, an amount of sodium, which is smaller in amount compared to the hypertonic saline. And also we should add the potassium if there is a hypokalemia associated with the hyponatremia. If the cause of the hypovolemia is diuresis or renal loss or diuretic use, we should stop the diuretics and basically treat the underlying cause. So, for example, we can give some medications for the nausea or vomiting to stop the underlying cause. And in cases of euvolemic hyponatremia, usually we just instruct the patients to restrict the water intake to be less than 1 liter per day and just treat the underlying, again, cause. That should be enough to treat the hyponatremia in those patients. And in cases of hypervolemic hyponatremia, usually, again, we instruct them to restrict the water intake to be less than 1 liter per day. We can use diuresis. You can use, for example, diuretics, or in case of heart failure or liver cirrhosis, and obviously treat the underlying cause. So that's for the treatment for mild and moderate hyponatremia.
Doctor, sorry, I have a question.
One important also, yes, sure.
For the
Yes.
3% hypertonic saline, we can use it in all three hyponatremia treatment?
Yes,
If
but
it's severe.
just in cases of severe hyponatremia, yes.
Okay.
Like, for example, when the patient presents with severe neurological symptoms, regardless of the type of hyponatremia, whether it was hypovolemic, euvolemic, or hypervolemic, we should go for the hypertonic saline as the first treatment line.
Okay, thank you.
Yeah, no problem. But just keep in mind, we use it only for severe hyponatremia with severe neurological symptoms. Otherwise, we treat the hyponatremia based on the most likely type of hyponatremia, either hypovolemic or euvolemic or hypervolemic. Okay. One more important point about the treatment of mild and moderate hyponatremia, which is the correction rate of sodium. There is a recommended correction rate of sodium, which is basically 10 to 12 milliequivalent per day. And for chronic hyponatremia, which happens over a couple of days, for example, 2 to 3 days, the correction rate should not exceed 6 to 8 milliequivalent per day. And most of the hyponatremia patients, they will require admission to the hospital. That's why, and that's because the sodium level usually is corrected over 2 to 3 days. And why do you think we have to correct it slowly? Do you know any condition or complication of rapid correction of sodium or hyponatremia?
To avoid cardiac arrest?
It has to do something with the brain.
The demyelination
Yes.
Okay.
syndromes.
Yeah, there is a syndrome that may result.
Central myelination, yes.
Yeah, so you're right. So the previous name for this condition is called central pontine myelinolysis, and the new name is the osmotic demyelination syndrome. Basically, for the ones who say the arrest, yes, cardiac arrest may be the final result of this syndrome if it was not treated rapidly. So we should avoid the rapid correction of sodium. We should avoid the rapid correction of sodium in cases of hyponatremia because it may lead to this syndrome, again called osmotic demyelination syndrome. Basically, it is caused by the large amount of sodium entering the brain, which will cause destruction of the myelin sheath and the neurons in the brain, which will cause severe neurological symptoms. So the neurological symptoms of this syndrome, think about it as if it was stroke symptoms. The patient may present with paralysis, dysarthria, or difficulty in speech, and dysphagia, and very severe cases, seizure, coma, and as you said, possible arrest and hypotension. So once we identify this syndrome in a patient who got rapid correction of sodium in case of hyponatremia, we should change the treatment. We should stop any IV fluid that contains sodium and replace it by 5% dextrose in water, which again will prevent further destruction of the myelin sheath in the brain. So that's it for hyponatremia. Any question regarding hyponatremia before we move on to the next disorder?
Yeah.
Okay. So let's move on to hypernatremia, which is basically a disorder of a high sodium level in the body. The definition of it usually it's a sodium concentration level above 145 milliequivalent per liter. And we see this condition mainly in patients who cannot get water easily. For example, intubated patients, infants who cannot mobilize, patient with mental impairments. Those patients usually they may have a hard time getting to a water source, and they may have a hard time expressing that they feel thirsty. That's why hypernatremia is kind of common in those types of patients. So the clinical features of hypernatremia, usually, again, they are non-specific. They are related to the main cause of hypernatremia. May include, again, nausea or vomiting, polyuria or polydipsia, which is basically increased thirst. Features of hypovolemia or hypervolemia, the ones that we talked about earlier. And in very severe cases, it may also lead to some neurological symptoms, such as seizure. So how can we evaluate a patient with hypernatremia? It's very similar to the way we talked about when we evaluate the patients with hypernatremia. Usually we send for urine sodium and urine osmolality levels, and we check also for the serum electrolytes level. And those, again, workup may help us with differentiating in between the possible causes. So in cases of hypovolemic hypernatremia, we expect the urine sodium to be low, again, in cases of GI loss or vomiting or diarrhea, such as vomiting or diarrhea, or third spacing, as we said previously. And we're expecting the urine sodium to be high in cases of diuresis, because basically the kidney is excreting the sodium. And this also may lead to hypernatremia in the serum as well. In cases of euvolemia, we may see hypernatremia in two main conditions, either hypodipsia, which is basically a condition in which the patient may have decreased sensation of thirst. And that's why the urine osmolality will be high in those patients, because the urine is going to be so concentrated because they don't drink enough amount of fluid. And in contrast to the syndrome of inappropriate ADH secretion, we may see the opposite condition here, which is the diabetes insipidus, in which the ADH level will be low, and this will cause, again, dilution of the urine. Because the ADH is again low, this will cause further diuresis, but in the same time will cause euvolemia or normal body volume and hypernatremia. In cases of hypervolemic hypernatremia, again, we classify the hypernatremia based on the body volume, as we did in the hyponatremia. This is a very rare condition, hypervolemic hypernatremia. We usually see it in patients with psychiatric illnesses who may present to the emergency department after ingesting a large amount of salt, or in very rare endocrine causes such as the primary hyperaldosteronism, which may cause, again, hypernatremia and hypervolemia. So we'll just talk briefly about the treatment of hypernatremia. It's kind of different than the treatment of hyponatremia. We usually classify it into three main steps. We should start those steps in order. So the first step is basically the volume replacement. And it depends whether the patient is hemodynamic stable or unstable. So in case of hemodynamic instability, we usually give a bolus of normal saline, like a 0.9%. And in case of hemodynamic stable patient, we usually go with half normal saline. And some of you may wonder why we give those patients. Why would us treat those patients with sodium-containing fluid and they have hypernatremia? Is this going to cause worsening of their hypernatremia or not? So the answer to that, usually no, because the concentration of sodium in those types of fluid are much less than the sodium level in the body volume in patients with hypernatremia. That's why this will cause basically dilution of the sodium in the body volume and will treat the hypernatremia in those patients. So once we replace the volume in those patients, we should move on to the next step, which is basically treating the underlying cause. As we talked earlier in the hyponatremia, we can use antiemetics for patients with vomiting or antipyretics for patients with fever. In cases of central diabetes insipidus, which may cause the euvolemic hypernatremia, we may use desmopressin, which is basically a medication that that will increase the ADH and reverse the central diabetes insipidus. In cases of impaired renal function, we may also go for dialysis. And in very rare cases, that the one we talked about, which is the acute salt ingestion, we usually dilute the hypernatremia again with 5% dextrose or hemodialysis. Once we are done with the second step, we should move on to the third step and the last step, which is basically the replacement of the total body water. As we said, because most of those patients are patients who cannot get to water easily or cannot feel thirsty. So their total body water is really low. That's why we have to also start them on 5% dextrose and water, or if they can tolerate oral intake, we just can instruct them to ingest the oral free water, just to replace the total body water. So as we talked earlier about the correction rate in hyponatremia, it's very similar in treating patients with hypernatremia. We should follow a certain correction rate. So in case of acute hypernatremia, usually it's 1 milliequivalent per liter per hour. And for chronic hypernatremia, the recommended correction rate is around 0.5 milliequivalent per liter per hour. And this is very important because rapid correction of hypernatremia may result in cerebral edema, because basically this will cause a significant drop in the sodium level in the brain and will cause a fluid accumulation in the brain, which is basically cerebral edema. And if this unfortunately happens, if the patient develops signs or symptoms of cerebral edema, this can also be treated. We should stop all of the treatment lines for hypernatremia and treat the patient with fluid restriction, or and we should also add some electrolytes to the fluid infusion that was started initially, just to kind of increase the sodium level in the brain. So that's it with the hypernatremia and hyponatremia. And one more thing about the correction rates for those two conditions. To achieve the correction rate, there are some equations that we can use. There are so many equations available. I did not include them in the presentation because I don't expect you to memorize them. Just know that there are some equations that can help us in achieving this correction rate. We can use those equations to get an infusion rate and achieve also the recommended correction rate for those two conditions. So that's it for hyponatremia and hypernatremia. I think this is the most difficult part of the lecture. Any question about those two disorders?
Clear.
Okay. Okay, so let's move on to potassium disorder. تبغون ناخذ بريك ولا ما عندكم مشكلة نكمل؟ لأن باقي بس البوتاسيوم والكالسيوم.
نكمل دكتور، مو مشكلة.
طيب تمام. So let's talk about potassium disorders. Again, we classify them based on the level of the potassium. So hyperkalemia, for example, is the condition in which the serum potassium level exceeds 5.5 milliequivalent per liter. The causes of hyperkalemia are a lot. The most common one is actually hemolysis, which is basically destruction of the blood cells, and this can be caused by like incorrect technique of getting the blood sample. We see this a lot in the emergency department, and usually if we get another correct sample, the potassium level will be actually normal, not actually high. So you can say this may actually cause false high potassium level. And the other causes that may cause hyperkalemia may include rhabdomyolysis, again, which may cause destruction of the muscle cells or muscular cells and release of the potassium into the vascular space. One also common cause of hyperkalemia, and we encounter this a lot, which is basically renal failure. We encounter this a lot in the emergency department. We see it a lot in patients who are on hemodialysis, who miss their dialysis session or get acute kidney injury on top of chronic kidney disease. We may see also hyperkalemia in patients who are taking some medications such as the angiotensin converting enzyme inhibitors or potassium sparing diuretics, which may also cause an increase in the potassium level. So the clinical features of hyperkalemia, again, unfortunately, they are non-specific. It may cause several clinical features. So, for example, in the cardiovascular system, it may lead to some arrhythmias, including ventricular fibrillation or interventricular blocks, or in very severe cases, death due to asystole. The neuromuscular effect may include weakness, paresthesia again, or paralysis. GI symptoms may include nausea or vomiting and other non-specific GI symptoms. So to evaluate a patient with hyperkalemia, usually we should perform ECG in all patients with hyperkalemia, because once we identify some ECG changes that are suggestive of hyperkalemia, we should start the treatment immediately, even without waiting for the actual potassium level. Because if the potassium is so high to the extent that it causes ECG changes, we consider this a kind of severe hyperkalemia that should be treated immediately to avoid further deterioration in the patient condition and possible arrest. So, and just one more point about this point that we just discussed. Usually we do this a lot in any patient with hyperkalemia, but specifically in patients who are on end-stage renal, on hemodialysis due to end-stage renal disease. So once we know that, and once we do ECG for them at the emergency department and identify the changes of hyperkalemia, we usually immediately start treating those patients, even without waiting for the potassium level. So this is an ECG of a patient with hyperkalemia. So can any one of you mention the findings that we can see here in this ECG?
U wave.
U wave. Okay, what do you think? Are there any other changes? So I will talk about U wave later on. But what do you think? Do you see any other abnormal changes in this ECG? What do you think about the T wave?
It's
Tall T
elongated.
waves.
Yes. Yeah. So the T waves, they look tall or peaked. Okay. What about the QRS complex before the T waves?
Widened.
Yeah. So it's wide as well. And as you can see in some of the leads, the P wave are actually absent. They are not very clear, or actually flat in some of the leads, like for example, lead V3. So yeah, and regarding the U wave, it's actually a finding of hypokalemia that we will talk about later on. So this slide just again summarizes the changes we talked about. The hyperkalemia again will cause tall or peak T wave and flattening of the P wave as well, and in very severe cases, QRS widening. And in very severe cases, we may see the sine wave, which usually look like the mathematical sine wave. And this is a very deadly finding or a rhythm. Once we see this, usually we anticipate possible cardiac arrest in those patients. Again, think about it as if someone is like pinching the T wave and dragging it above, and this will cause again prolongation of the T wave and flattening of the P wave and widening of the QRS complex. Okay, so we'll talk about the treatment of hyperkalemia. So as we said, the ECG is the most important workup on those patients, because once we see some ECG changes, we immediately start the treatment for hyperkalemia, even without waiting for the potassium level. And usually we start the treatment in those patients with a class of medication called cardiac membrane stabilizers, and they include calcium chloride or calcium gluconate. And again, this should be the first medication that should be given in patients with wide QRS complexes. And some resources say this should be given in patients with any ECG change, which may include tall T wave or flat P wave. Once we see it, some resources recommend also using calcium gluconate or chloride in those patients. And the reason why we use those medications, because calcium again helps with the inhibition of the overstimulation of the cardiac muscles caused by the high potassium level. So it's kind of the antagonist of the potassium on the cardiac muscle. It antagonizes the effect of potassium on the cardiac muscle. That's why it stabilizes the heart muscles and prevents arrhythmias. The second class of medications for hyperkalemia called the potassium shifters, or the medications that basically shift the potassium into the cells. And the examples for those medications may include insulin with dextrose, and albuterol, which is also called salbutamol, and the sodium bicarbonate. And basically the insulin with dextrose, again, this will cause shifting of the potassium into the cell, but just keep in mind the dose of insulin in patients with renal dysfunction should be lower, which is basically 5 units instead of the 10 units that we use in other regular or other patients with no renal impairments. And the reason for that, basically because patients with renal impairment will actually have very limited ability to excrete insulin in the urine. So as a result of that, do you expect those patients to have high blood glucose or low blood glucose?
Low
What do you
blood
think?
glucose.
Exactly. So that's why we should give a lower dose of insulin just to prevent further drop in the glucose level in those patients. And the other medication, as we said, is albuterol, or called the salbutamol, and we can give it in a nebulized dose through a face mask. We can also use the sodium bicarbonate, but usually we don't use this medication unless the patient is severely acidotic. For example, in a patient with a pH level of less than 7 or 6.9. So the last type of the antihyperkalemic medications are basically the potassium removers, or the medications that remove the potassium from the body. And they may include either diuretics such as furosemide or hemodialysis. And just keep in mind that furosemide may actually not work in patients with end-stage renal disease, basically because those patients cannot excrete urine. So we avoid it usually in those patients, and we usually go for hemodialysis in those patients. So we can use hemodialysis urgently in those patients with renal failure, and we also can use the hemodialysis emergently or as soon as possible in cases of cardiac arrest. So just to summarize, usually if there is ECG changes, we immediately go for calcium. Then we can give 2 of the potassium shifters, for example, insulin with albuterol at the same time. And if the patient is severely acidotic, we can give sodium bicarbonate. If the patient is known to have end-stage renal disease and, for example, missed the dialysis, in addition to those treatment lines, we can initiate hemodialysis in the emergency department. And in cases of the patient went into cardiac arrest, we also can start the hemodialysis while we resuscitate the patient with CPR. Okay. One more point about the treatment of hyperkalemia. You may hear about an old medication called calixylate, or sodium polystyrene sulfonate. this is an outdated medication that is not recommended anymore. We don't use it anymore in the emergency department or any other departments of the hospital because it has been associated with so many gastrointestinal side effects, including GI necrosis and perforation. And that's why it's not used anymore in the treatment of hyperkalemia. So that's it for hyperkalemia. Any questions about hyperkalemia before we move on to the next disorder?
No, it's clear, doctor.
Tamam. So we'll move on to the other potassium disorder, which is the hypokalemia. Basically, it's defined as the potassium level of less than 3.5 milliequivalent per liter. And the causes of hypokalemia, there are so many causes of hypokalemia. They may include some, again, GI loss like vomiting or diarrhea, renal losses such as diuresis or use of diuretics. And basically, if we use the medications that we talked about in the treatment of hyperkalemia may cause hypokalemia. So, for example, the beta agonist or salbutamol, again, insulin, those are all possible causes of hypokalemia because, again, they will shift the potassium into the cell. So if we use large doses, we may actually cause hypokalemia in those patients. So clinical features similar to the hyperkalemia, unfortunately, they are non-specific. The hypokalemia may cause some neurological symptoms such as paresthesia or lethargy, may cause also some muscle weakness or cramps. And hypokalemia actually may cause a very unique condition called periodic hypokalemic paralysis. And we see this quite often in the emergency department. Those patients may present only with paralysis, and we find that their potassium level is low. And once we correct the potassium level, they immediately start to walk and move their limbs. It's a very unique condition, and we see it a lot in the emergency department. Cardiovascular complication or manifestation of hypokalemia may include, again, some types of arrhythmias that we'll talk about later. Again, the clinical features of hypokalemia may include GI symptoms such as nausea or vomiting. So let's talk about the findings, ECG findings of hypokalemia. So can any one of you mention the findings that we can see in this ECG, the abnormal findings? What do you think?
كلها فوق.
كلها فوق ايش الكوارث كومبلكسز قصدك؟
absent P wave أو widened P wave.
لا فلات تي ويف.
اوكي فلات تي ويف. اوكي البي ويف لا موجوده في بعض الليدز.
prolonged
U wave I think between V2
Yes.
and V5.
Yes, exactly. So we see a U wave and flattening of the T wave, and some of the leads may actually show an inversion of the T wave or ST depression such as V3. And the U wave, basically, it's a wave, an extra wave between the P wave and the T wave. It's very obvious in, for example, V2, lead V2, and we will talk about it more in the next slide. It's going to be obvious. So those are the changes of hypokalemia. As we said, it may cause a ST depression or flattening of the T wave, an extra wave or called U wave just before the next P wave, and prolongation of the QT interval as well. And in very severe cases, it may lead to arrhythmias or heart blocks, such as the first or second degree heart block, atrial fibrillation or ventricular fibrillation, or in very severe cases may lead to cardiac arrest due to asystole. Okay, let's talk about the treatment of hypokalemia. So it really depends on the severity of hypokalemia and whether the patient tolerates oral intake or not. So in cases of mild hypokalemia, and if the patient tolerates PO intake, we usually go for the oral potassium chloride replacement. and we can actually discharge the patient on the oral potassium replacement. And in cases of severe hypokalemia, or if the patient cannot tolerate oral intake, we usually go for the IV potassium replacement using IV potassium chloride. And again, we use it in severe hypokalemia or symptomatic moderate hypokalemia, or in cases of severe arrhythmias or prolonged QT, or when the patient cannot tolerate oral intake because of, for example, repeated vomiting or nausea. And one more important point about the treatment of hypokalemia, we have to always put the patient on a monitor and make sure that the patient does not develop any arrhythmias while we treat the patient with potassium, because again, we don't want to cause hyperkalemia in those patients and development of arrhythmia because of the hyperkalemia and possible arrest. And usually we have also to replace the magnesium when there is low magnesium level as well, when we check the other serum electrolytes in the body, because again, magnesium replacement helps with correcting the low potassium level in those patients. Okay, so that's it for the potassium disorders. Any question about the potassium disorders?
واضح دكتور.
تمام. one more point، أنا عشان كذا حطيت صورة الموز مع البوتاسيوم disorders. Usually bananas are very rich in potassium. So that's why one of the tricks that I usually instruct my patients when I discharge them, I mean the hypokalemic patient, when I discharge them from the emergency department, I usually instruct them to eat bananas just to make sure that they do not develop hypokalemia again, and prevent like revisits to the emergency department for the same reason. So I just instruct them to like have at least one banana per day for the next 5 days. Just fun fact, just to help them with avoiding hypokalemia again. Okay. The next and last electrolyte disorders that we'll talk about, which is related to the calcium electrolytes. First one is the hypercalcemia, which is basically defined as calcium level above 10.5. It may be caused by so many causes, but mainly we see it in patients with some malignancies such as multiple myeloma or metastatic cancer to the bone. We may see it also in some endocrine causes or endocrine disorders such as the hyperparathyroidism, because as you know, the parathyroid hormone is the main hormone that regulates the calcium and phosphate in the body. So when it gets elevated, usually it causes high calcium level as well. We may also see it in patients who are using some medications such as thiazide, diuretics, and vitamin A. And in very rare cases, we may see it in cases of rhabdomyolysis, which is basically a condition that may cause destruction of the muscle cells again, and release of the calcium from the muscle cells into the vascular space. So clinical features of hypercalcemia, I would say the calcium actually may, the calcium electrolyte disorders may actually cause some unique clinical features compared to the other electrolyte disorders. For example, hypercalcemia may cause severe CNS symptoms such as seizure or coma, may cause, again, some cardiovascular complications such as bradycardia, AV blocks, or ventricular tachycardia. It may cause some bone pain, basically because in some conditions that may cause hypercalcemia, such as multiple myeloma, there will be a destruction of the bones and release of the calcium into, again, the vascular space. And in some cases, we may see hypercalcemia in patients with renal stones, because as you remember, the renal stones are the most common type of renal stone. So very high calcium level may actually cause development of stone in the kidneys. And in very rare cases, we may see actually some neuropsychiatric symptoms such as depression or hallucination, because again, the calcium play a major role in regulating the mood. So we'll talk more now about the ECG changes or the cardiovascular changes caused by the hypercalcemia. So there is an arrow here pointing to the abnormality. So can any one of you guess the finding in this ECG?
Short QTR.
Yes, short QT interval. You're right. Just to memorize it, high calcium will cause short QT, low calcium will cause prolonged QT. So just reverse the ECG finding with the level of the calcium. And just this is an easy way to remember it. And to tell if the QT interval is short or prolonged, usually we look at the T wave, the position of the T wave. If it's very close to the previous QRS complex, and if it's in the first half of the interval between the QRS complex and the next one. So, for example, usually we count how many large boxes in between those two QRS complexes. Let's say, let's take V2 for example. So there's 1, 2, 3, 4, 5 boxes here, and the T wave is very close to the previous QRS complex, and it's in the first half or the first two boxes of the large boxes of the QT interval, or the interval between the two QRS complexes. That's why we said it's short in this ECG. This is a very rough and very quick way to tell, but usually most of the ECG machines, they will tell you if they will calculate the QT interval based on some formulas, and they will tell you exactly the length of the QT interval in milliseconds. So again, just to show you the finding that we talked about earlier, in case of hypercalcemia, we're expecting the QT interval to be very short and very close to the previous QRS complex. In very rare cases, we may see an extra wave just next to the QRS complex, which is called the Osborn wave. Again, it's not a specific wave for hypercalcemia. We may see it in another conditions, but just keep in mind, we may see it also in hypercalcemia. Okay, so how should we treat hypercalcemia? Usually we can treat it by so many treatment lines. Usually we treat all of the patients with hypercalcemia with normal saline, which is the 0.9%. And usually we start with the volume repletion in those patients using 500 to 1,000 milliliter per hour. And usually we follow this with saline infusion, which is basically at a rate of 200 to 300 milliliter per hour. And we target the urine output. That's why we usually put a Foley catheter on those patients and monitor the urine output to achieve a urine output of 2 liters. Again, this will cause just dilution of the calcium level in the body and will help with lowering the calcium level in those patients. And in all of those patients, we use also furosemide or the diuretic just to avoid the hypervolemia, which can be possibly caused by the large amount of fluid we give to treat the hypercalcemia. So it's not used, the furosemide is not used to treat hypercalcemia, it's used just to avoid the volume overload in those patients. Then we choose one of the next 3 medications, either bisphosphonate, corticosteroid, or calcitonin. And usually we use one of them based on the most likely cause of hypercalcemia. So for example, we can use bisphosphonate if we are suspecting the hypercalcemia to be caused by some malignancies or metastasis to the bone. And it's also recommended in case of high calcium level of 12 milligram per deciliter or more than that. In cases of endocrine causes that may cause hypercalcemia or steroid-responsive malignancies, such as multiple myeloma, we can go for corticosteroid, such as prednisolone or hydrocortisone. Those, again, both of those medications, or actually all of those three medications, in addition to the calcitonin, they will inhibit the destruction of the bone and will inhibit further release of calcium into the blood, and as a result will treat hypercalcemia. And the last treatment line for hypercalcemia may include also hemodialysis. And we rarely use it to treat hypercalcemia. We usually only use it just in cases of cardiac arrhythmias due to hypercalcemia or severe heart blocks. But otherwise, we don't usually go for dialysis if there are no severe cardiovascular manifestation of hypercalcemia. Okay. Any question about hypercalcemia before we move on to the last electrolyte disorder?
Clear. شكرا.
تمام. So the last electrolyte disorder, which is basically hypocalcemia, basically it's defined as the low calcium level of less than 8.5. The causes of hypocalcemia, they are can be classified into so many causes. May include the low albumin level, basically because the albumin helps with regulating the level of calcium and binds to the calcium. So if there is a low albumin level, this will cause also low calcium level in the body. Again, in contrast to the same point we talked about in hypercalcemia, hypoparathyroidism may cause hypocalcemia because, again, the parathyroid hormone regulates the calcium level, and low levels of the parathyroid hormone will cause low calcium levels. Vitamin D deficiency, again, because vitamin D helps with the absorption of calcium, and other conditions such as pancreatitis and some medications that we talked about in the treatment of hypercalcemia may cause also hypocalcemia if they were used in large doses. Okay, so what are the clinical features of hypocalcemia? Again, it may cause some unique features, such as some numbness or tingling around the mouth, which is called the perioral paresthesia, or some tingling in the fingers called the digital numbness or digital paresthesia, and may cause also some confusion and hallucination similar to the hypercalcemia, may cause also some severe cardiovascular manifestations such as ventricular arrhythmias or heart failure. In the physical exam, we may actually see some unique features as well. The hypocalcemia may cause two main signs, which are called the Trousseau sign and Bostic sign. Basically, the Trousseau sign, we can observe it by just inflating blood pressure cuff, and this will cause contraction of the carpopedal muscles or contraction of the fingers in the same limb. Basically, because low calcium level may lead to like overstimulation of the neurons or the muscles in those patients. So with even simple stimuli like the blood pressure cuff inflation, this may cause contraction of the muscles in the same area. And similar to the Trousseau sign in the face, when we tap the one side of the face, this will cause contraction, again, because the muscles are easily stimulated in patients with hypocalcemia, because the calcium level helps with the, again, regulating the contraction of those muscles. So low levels will cause easy stimulation of those muscle contraction. And as we said, so tapping in one side will cause contraction in the same side of the face in cases of hypocalcemia. Okay, so this is an ECG of a patient with hypocalcemia. So can anyone of you again tell me the abnormal findings that we may see here? What do you think?
long QT.
Yes, exactly. So it's the exact opposite finding in hypercalcemia. Again, we see long QT because the T wave is in the second half of the interval in between the two QRS complexes. Two QRS complexes next to each other. And it's not very close to the previous QRS complex. And again, this is just a rough estimate. But the new ECG machines, they usually tell you the exact or the corrected QT interval. So this is again just to clarify the finding we talked about. The QT interval will be prolonged, and if this was not treated, it may lead to a deadly arrhythmia called torsade points, which is basically a type of polymorphic ventricular tachycardia in which the QRS complexes will twist around the ECG line or the isoelectric line. And again, this is a very fatal arrhythmia that may result if the QT prolongation was not treated or if the hypertension was not treated early. So last slide, we'll talk about the treatment of hypercalcemia. Usually we can treat it by so many options, including either the oral replacement or the IV replacement. Usually we go for the oral calcium replacement in patients with asymptomatic hypocalcemia or patients with very mild symptoms. And we usually go for the IV calcium replacement for patients with severe or moderate symptoms. And just keep in mind that calcium replacement, when it's given through the IV line, it's usually very irritating to the veins. So we usually give it through a central line, which is a venous line that is larger in diameter, and we usually insert it in one of the large veins in the body, like the femoral vein or the internal jugular vein or the subclavian vein. And as we said in the treatment of potassium disorders, we should always put those patients on continuous monitoring, again, because continuous replacement of the calcium through the IV line may cause, again, some arrhythmias or accidental hypercalcemia, for example, and arrhythmia. So we should always keep them on cardiac monitoring while we replace the calcium by the IV replacement method. One last point about the magnesium replacement. It should always be considered in patients with also hypomagnesemia and hypocalcemia, again, because magnesium helps with the replacement of the calcium level and regulating the calcium level in the body. So that's it for the electrolyte disorders. I just included two references for your own references. You don't need to go back to those books and read about electrolyte disorders for your exam. But I just kept them if you want to read more about them and to get further details about the electrolyte disorders we talked about during this lecture. So that's it for this topic. Do you have any question regarding any electrolyte disorder we talked about today?
لا واضح كل شيء، الله يجزاك خير.
تمام، ممتاز. بس دقيقة بتأكد من الحضور إذا كلكم مسجلين أسماءكم. أنتم عددكم 26 ولا في غياب اليوم؟ ما أدري أنا موجودة ولا؟
دكتور عددنا 28.
28. طيب. ممكن أنت ما أدري حضرتي حنان على الورقة اللي أرسلتيها لي ولا لا؟
بحضر، لا بحضر الدكتور وأرسل لك.
خلاص تمام، لأن الظاهر إني لازم أوقع عليها محتاج أنا نسخة بس أرسلها إلى منسق المادة اللي هو دكتور عبد الله السقا. تمام. فإذا ما عندكم أي سؤال يعطيكم العافية جميعا. ما قصرتوا، والتوفيق لكم جميعا إن شاء الله.
شكرا.
يعطيك العافية دكتور، شكرا ما قصرت.
يعطيك العافية دكتور، شكرا.